The title of this talk is Physiology of the Upper Motor Neuron, Cortex, and Brainstem. The talk will be conducted using conversational and question and answer formats. These are the class objectives. You do not need to read them. We will use them to chart our talk. The first question is, a motor neuron descending a spinal tract does not originate from dash A. Superior olives, B. Inferior olives, C. Superior colliculi, D. RAF nuclei. Each half of the spine can be divided in 3 funiculi. One of the tract in the anterior funiculus is the anterior pyramidal tract. Fibers from the anterior pyramidal tract make contact directly with lower motor neurons or with interneurons. The anterior pyramidal fibers descend ipsilateral to their origin in the spinal cord and cross in the white commissure once close to their intended lower motor neuron or interneuron. The lower motor neuron or interneurons the anterior pyramidal tract makes contact with are mainly involved with axial musculature. In the anterior funiculus, we also have other tracts that make contact with interneurons. The descending fibers that make contact with interneurons are those from the pyramidal tract that we have just mentioned, as well as those that I am about to mention. These brainstem to spinal cord tracts arise from the inferior olive. The fibers from the inferior olive cross in the brainstem and descend only as far as the cervical spine. The reticular formation. The tract formed from the reticular formation has extensor bias upper motor neurons and it modulates muscle spindles. Another nuclei that projects to the spine from the brainstem is the vestibular nuclei. The nuclei from these tracts provide excitatory input for extensor and anti-gravitatory muscles. And from the tectum. The tectospinal tract arises from the contralateral superior colliculi crossing in the brainstem and mediating head-turning movements in reaction to sudden visual, auditory, and tactile stimulations. In this frame, you can better appreciate the anatomical location and trajectory of the tracts I have just mentioned. Here you can see the left reticulospinal tract arising from the left pontine and medullary reticular formations, especially RAF magnum nucleus. Here, the left lateral and medial vestibular spinal tracts. Here, the tectospinal tract arising from the contralateral superior colliculus and crossing in the brainstem. The last tract in this frame is the olivospinal tract, which also appears to cross soon after its formation. So the answer to this question is A. Next question. Which of the following tracts travel in the lateral funiculus? A. Tectospinal tract, B. olivospinal tract, C. rubospinal tract, D. vestibular spinal tract. The lateral funiculus can be divided based on the location of the dentate ligament into anterior segment and posterior segment. In the posterior segment, here depicted in bright blue, and the largest is the lateral or main pyramidal tract in command of voluntary movements for the limbs. Another tract in this area is the rubospinal tract. This tract originates in the contralateral red nucleus, crossing to the other side shortly after leaving the red nucleus and going down. This cross tract is involved in the modulation of flexor movements of the upper limbs. In this frame, you can see the trajectory of the rubrospinal tract. Notice that shortly after its origin, this tract crosses to the other side. The specimen I have introduced corresponds to a coronal cut going through the red nucleus. The red nucleus is indicated by the arrow. So the answer to this question is C. Next question. The corticated patients have their arm flexed. A true, B false. In this frame, you can see the rubrospinal tract. And now the vestibulospinal tract. A cut above the red nucleus, disconnecting the red nucleus from the brain region above, produces decortication. This is so because the upper extremity flexion preference of the red nucleus exerted upon a spinal neuron is no longer being modulated by higher brain centers. A cut below the red nucleus but above the vestibular nucleus produces decerebration. This is so because the extensor prevalence of the vestibular nucleus exerted upon spinal cord neurons is not checked by higher brain centers, including the red nucleus. So, the cortication is characterized by arm flexion, the hands going to the heart, as you see in this frame, and leg extension. With midbrain involvement, the red nucleus flexion facilitatory influence disappears, and the vestibular nucleus extensor influence prevails, producing decerebration characterized by upper extremity extension and leg extension. So the answer to this question is A, true. Next question. A single small structural brain lesion cannot produce simultaneous weakness in the right arm and the left leg. A, true, B, false. These multiplication signs represent the pyramidal decussation. Here I have introduced a cut at the indicated level. Notice the massive crossing of fibers. The crossing is indeed massive but also sudden and peculiar. 90% of fibers cross suddenly. They travel on the contralateral side of the spine and make contact with neurons also in the contralateral side. I have represented the connection by the offshoot green lines. 2% do not cross and go ipsilaterally to reach the anterior segment of the spinal cord, but ultimately cross to the other side. 8% do not cross and go to the ipsilateral funiculus, that is to the ipsilateral lateral funiculus, and make contact with neurons in the same side. But what is really unusual and at times clinically important is that arm fibers go down in the pyramid medially, cross high in the decussation, but remain positioned medially, as seen in this frame. Whereas leg fibers come down in the pyramids more laterally, cross below the fibers for the arms, and then take a more lateral position. The clinical importance of this arrangement can be appreciated in the following frame. Here, the patient is a 12-year-old boy that is attempting to raise both arms and both legs simultaneously. And as you can see, the right arm is weak and so is the left leg. This is called hemiplegia cruciata. This patient MRI showed basilar impression, that is a craniocervical junction abnormality where the tip of the odontoid process projects above the foramen magnum, chiari malformation, a condition in which brain tissue extends into the spinal canal, and syringomyelia, which consists of a cyst or cavity formation within the spinal cord. So this patient has hemiplegia cruciata. It is due to a lesion at the site shown by the red burst. The arm fibers are injured after crossing and the leg fibers before crossing. This is one to remember because you may find a patient with it and you may find it in your exam. So the answer to this question is B. Next question. The voluntary cortical motor fibers for the face travel anteriorly to other voluntary motor fibers in the internal capsule. A true, B false. During autopsy, the classical cuts of the brain are made in the coronal plane as shown in this frame, in the transverse plane as shown here, in the parasagittal plane, or in the mid-sagittal plane. In a mid-sagittal brain cut as shown here, after removing the left side, you will get to see the mesial cerebral cortex, the split corpus callosum, the right thalamus, the right hypothalamus, as well as split brainstem and cerebellum. I have now placed the right half of the brain in this side of this frame to show different cuts that would allow us to trace the volitional motor fibers from the cortex to the spine. A coronal cut through the anterior gyrus, paracentral lobule, and the precentral gyrus in the lateral surface as indicated by the aqua line will allow us to see the homunculus. We will see the representation of the muscles of the larynx. A little higher, we'll find the representation of the face. A little more superior, the cervical muscle representation, which includes the hand. More medially, we find the representation of the thorax, and mesially, the representation of the lumbosacral muscles. Also represented in this figure are the corresponding fibers coming together deeper in the brain parenchyma. A transverse cut at the level of the thalamus is represented here. It will show the internal capsule. The facial fibers are located anterior to all volitional motor fibers. So the answer to this question is true. Next question. The voluntary cortical motor fibers for the cervical spine travel laterally to other voluntary motor fibers in the brainstem. A true, B false. The cervical fibers, which, as we previously mentioned, include the fibers for the upper limb, are dorsal to the facial fibers. We find the thoracic fibers more dorsally. The lumbosacral fibers are most dorsal. If we now make a transverse cut through the upper part of the brainstem, we will see the cerebral peduncles. In the peduncles, we will find the facial fibers are most medially located and the lumbosacral fibers most dorsally located. If a slight lower cut is made, we will see the pontine parenchyma. Here, I want you to notice three things of clinical importance. Notice two green structures in the pontine tegmentum. They represent the trigeminal motor nucleus and the facial motor nucleus. Also notice that the fibers of these nuclei leave the pyramidal tract way above the level of said nuclei. and that only those fibers destined for the tongue remain within the pyramidal tract at the level of the pons. If we now cut at the level of the mid-medulla, we will notice that the fibers for hypoglossal nucleus are no longer traveling in the pyramidal tract because they have already separated from it and crossed the midline. And only the fibers for the spinal nerve are represented at this level. At this level, the cervical fibers are most medial, the lumbosacral fibers most lateral. A cut a little bit lower in the medulla, close to the cervicomedullary junction, will show the decussation of the pyramidal fibers, as you can see here. Also notice that despite the decussation, the cervical fibers remain medial and the lumbar fibers lateral. So the answer to this question is B. If you get it wrong, stop the video and spend a few minutes looking at this drawing. The next question is, the thalamus is one of the structures that form the inner boundary of the internal capsule. A true, B false. If we select the transverse cut indicated by the arrow, we would see this view. In it, we would be able to identify the lateral ventricle, head of the caudate nucleus, putamen, globus pallidus, and the thalamus. We will also see the anterior arm of the internal capsule, the genu of the internal capsule, and the posterior arm of the internal capsule. If instead of a transverse cut, we do a mid-sagittal cut, you will see this view. In it, I have superimposed a cartoonish representation of the head of the caudate and part of its tail, and the thalamus. Further dissection towards the lateral surface will first reach and remove these two structures, allowing us to see their indentation made by this structure upon the internal capsule. Thus, we will be able to see the anterior limb of the internal capsule, the posterior limb of the internal capsule, and between them, the genu. In the internal capsule, as we have previously mentioned, fibers for the face are most anterior and those for sacral muscles most posterior. These are the fibers going for voluntary motor activity. Facial fibers travel in the genu. So the answer to this question is A. Next question. The corticobulbar fibers are in the dash of the internal capsule. A. Anterior arm. B. Posterior arm. C. Genu. This label image was presented to you previously. To it, I have just added a rectangle. I have done so to isolate this area. Here I have enlarged it. I will use this enlargement to illustrate the trajectory of the volitional motor fibers. As you can see here, corticobulbar fibers destined to innervate the brainstem nuclei, that is, the striated muscles in the face, course in the genu. Then those for the arm, and most posterior, those for the leg. So the answer to this question is C. Next question. A same-size cerebral infarct involving the pyramidal tract causes more extensive neurological deficit in the centrum semio-valley than in the internal capsule. A true, B false. This is a coronal cut going through the internal capsule. Here I am indicating the cortex, centrum semiovale, internal capsule, cerebral peduncle, pons. The structure I have just added corresponds to the right facial motor nucleus, and the structures just added in purple corresponds to the hypoglossal nuclei. I have now introduced the motor lumbosacral fibers, the thoracic motor fibers, the cervical motor fibers, and the motor fibers for the face, including the tongue. So, as you can see, the right facial motor nucleus upper segment is receiving fibers from the right hemisphere. So does the left hypoglossal nucleus and the right hypoglossal nucleus. Notice that just below the hypoglossal nuclei, the fibers for the cervical, thoracic, lumbosacral regions cross to the other side. In this frame, I have added the left hemisphere corticobulbar fibers going to the upper segment of the right facial motor nucleus and to the lower segment, as you can see in this frame of the same nucleus. I have now included the left corticobulbar fiber going to the right hypoglossal nucleus and left hypoglossal nucleus. I have now added the figure of a body. R corresponds to the right side. I will use this figure to indicate the areas involved by lesions at different locations. Thus, a lesion of a relatively small size in the centrum semivalley, as indicated in this frame by the red burst, will only produce deficit in the contralateral cervical innervated muscles, that is, in the contralateral arm. A similar size lesion in the internal capsule will produce contralateral hemiparesis, including weakness in the lower facial quadrant. So the answer to this question is B. Next question. The sparing of upper half of the face with an internal capsular lesion is due to bilateral cortical innervation of the upper half of the facial motor nucleus. A true, B false. This patient suffered a right internal capsular stroke. This patient has a facial asymmetry. On the left, you can see a facial dimple, but not on the right. On the left, the corner of the mouth is higher than on the right. So the right side is good and the left side is bad. Yet the creases in the forehead are symmetrical. Notice that the depth here and here is the same. This finding is called upper half of the face sparing. The question is why? Why upper half of the face sparing occurs with internal capsular stroke? We will, for now, go along with the classic explanation for this phenomenon. This is the lateral side of the left hemisphere of the brain. Now I have introduced a cartoon representation of the cortical area of the face. And now I have done the same on the right side. Here I have drawn the right paracentral gyrus with the facial representation of the homunculus. And here I have done the same on the left. Now I am introducing a cut of the midbrain pons to illustrate the position of the facial motor nuclei in the tegmentum. In this frame, I have removed the pontine specimen so we can better see the nuclei. The neurons in the left hemisphere upper region of the facial cortical representation send fibers to about, but no more than, 50% of the neurons in the top half of the right and left facial motor nuclei, as represented here. The neurons in the left hemisphere present a gyrus lower facial representation area, send fibers to innervate 100% of the neurons in the lower part of the right facial motor nucleus. The right hemisphere cortical neurons in the area of the upper face send fibers to innervate about but no more than 50% of neurons in the upper half of both facial motor nuclei, as illustrated here by the yellow squares in the upper half of both facial motor nuclei. The neuron in the lower part of the facial homunculus in the right hemisphere send fibers to innervate 100% of neurons in the lower part of the left facial motor nucleus, as indicated here by the arrow, and illustrated here by changing of the color from white to yellow. I have now introduced a face and a comment. Facial muscles of expression only become noticeably weak if more than 50% of their fibers are deprived of innervation. I will use this arrangement to bring about a schematic representation of the innervation of the muscles of expression based on our previous discussion. I will use this schematic representation to explain the motor deficit that results from lesions at different anatomical locations. In this frame, I have introduced the right and left facial motor nuclei, as we have previously depicted them. These nuclei send nerve to ipsilateral upper and lower quadrant of the face, traveling together during most of the interparenchymal course and in the facial nerve. The upper half of the right facial nucleus receives innervation from the right upper cortical facial representation and from the left upper facial cortical representation. Hence, the fibers for the right upper quadrant of the face receive bilateral cortical influence, as depicted here. The upper part of the left facial motor nucleus is innervated in the same fashion as illustrated here. Thus, the fibers for the left upper facial quadrant, as those for the right upper facial quadrant, have bilateral cortical influence. The lower half of the right facial motor nucleus only receives left cortical fibers, and it innervates the lower right quadrant of the face. Thus, this quadrant will solely be influenced from the left hemisphere. The lower half of the left facial motor nucleus only receives innervation from the right hemisphere. So, the fibers going to the left lower quadrant of the face are only influenced by the right hemisphere, as indicated here. And the new structures I have just introduced illustrate the position of the facial nucleus in the pons, with some internal fibers coursing in it before the formation of the nerves. I will now, as promised, use this diagram to explain the findings produced by injury at different anatomical locations. I am representing a lesion in the right internal capsule, as the patient in this question is said to have had, by coloring the structure red. Such a lesion will involve the right cortical lower facial motor neuron fibers, so the fibers innervating the lower left facial motor nucleus go, as you can see in this frame, depriving the lower half of the left facial nucleus of innervation. These neurons die, and so do their axons as indicated here, leading to weakness in the left lower quadrant of the face. The cortical fibers from the right upper part of the face going to the left upper half of the facial motor nucleus also die, but since they innervate only 50% or less of neurons in this segment of the nucleus, despite death of their axons and the muscles in the left upper quadrant of the face being deprived of innervation, no weakness will be present. Because, as we previously mentioned, the innervation muscle do not add up to more than 50%, a requirement in order for weakness to be appreciated clinically. The rest of the fibers from the right cortical area also die in the case of a right internal capsule lesion. Once deprived of innervation, the neurons of the upper part of the facial motor nucleus also die. This is followed by death of their axons and the innervation of the corresponding muscles. But again, since only 50% of the fibers or less are involved, no weakness will be detected. And since similar fibers involvement is present on both sides, no asymmetry will be noticed. Now we will go back to the photograph of the patient. Notice that weakness is only present in the left lower quadrant, which I have shaded red, and that the forehead is spared. So the answer to this question is A. This patient has dash facial palsy, A, central, B, peripheral. Deciding if a patient has a central or peripheral facial palsy, that is, if the deficit is due to an upper motor neuron problem or central, or due to a lower motor neuron problem or peripheral, is often easy if you know when to look for it and what to look for. You certainly cannot tell by looking at an sleepy neonate if there is a facial weakness. But facial weakness is easy to detect when the neonate is crying, and a quick observation can lead to two simple but important conclusions that will help you decide what the problem is. The first conclusion is that the right side is normal, the left is not. The second conclusion is that the upper quadrant and the lower quadrants are affected. I will now represent these conclusions schematically. This is the figure we have introduced before. In this patient, the loss of function of the left side of the face is represented in red. This deficit is consistent with a left lower motor neuron facial lesion. A lower motor neuron lesion can occur due to a lesion in one of three anatomical structures: the nerve, the intraparenchymal fibers, or the nucleus. A lesion at these sites is considered a peripheral seventh nerve palsy, despite the fact that the lesion can be found in the central nervous system in two of these instances. The etiology of this patient's peripheral facial palsy was trauma to the facial nerve. So the answer to this question is B. Next question. The anterior belly of the digastric muscle is innervated by the facial nerve. A true, B false. The facial nerve innervates many structures with many different functions. I will use this diagram to describe them. I will start by pointing out some landmarks in this diagram. This is the brainstem represented from the back. The four circles represents the quadrigeminal plate. This represents the internal auditory meatus, the opening of the facial canal, the exit of the facial canal, called the stylomastoid orifice, the stapedius, the mastoid process, styloid process, and the hyoid bone. Now I am pointing to the digastric tendon attached to the hyoid bone. I will now name some of the muscles and trace them at their appropriate location, and I will also indicate the trajectory of the facial nerve motor fibers innervating them. As you can see in this frame, the first muscle I will mention is the muscle of the stapedius. This muscle hampers sounds. Now I am pointing to muscles of expression innervated by the upper part of the facial motor nerve nucleus. Notice that the lines are magenta and yellow, indicating bilateral innervation. I am now pointing to muscles of expression. These muscles are innervated only from the cerebral cortex in the opposite hemisphere, since they are in the lower part of the face. These muscles include the platysma. This is a drawing of this muscle. This is a photograph of a patient with a left facial paralysis showing good contraction of the right platysma and no contraction of the left platysma. Notice the contraction of the muscle being pointed by the arrow. This is the same patient. In the top picture you can see during no contraction. In the bottom pictures you can see during contraction. Notice the difference. The right being normal, but no contraction on the left. Another muscle innervated by the facial nerve is the posterior belly of the digastric muscle and the stylohyoid muscle. These two later named muscles are important for respiration. So the answer to this question is B. It is the posterior belly of the digastric muscle that is innervated by the facial nerve. Next question. The geniculate ganglion has dash neurons. A. Somatosensory and motor. B. Somatosensory and parasympathetic. C. Somatosensory and taste. D. Taste and parasympathetic. I have now gone back to the original sketch to introduce the taste fibers for the anterior two-thirds of the tongue and palate. The taste peripheral neurons are in the geniculate ganglion. I have now added the parasympathetic ganglia going to the lacrimary and salivary glands. The peripheral neurons are in the pterygopalatine and submandibular ganglia. And now I have added the sensory fibers. These fibers supply sensation for the area behind the ear, area in the ear canal, and in the tympanic membrane. The bodies of these neurons are in the geniculate ganglion. So the answer to this question is C. Next question. Patients with facial nerve lesion in the facial canal will dash normally. A. Tear, B. Taste, C. Hear, D. Salivate. This figure shows all non-striated components of the facial nerve. Now I have added the facial motor nucleus and the fibers going to a stapedius muscle. I will use this figure to explain the findings that result from a lesion above the facial canal and within the facial canal. I will first address the findings produced by a lesion above the facial canal at the site indicated by the cross. In such cases, we will see hemifacial weakness in the muscles of expression, no tears since the preganglionic parasympathetic fibers to the pterygopalatine ganglion are damaged, hyperacusia since the fibers to the stapedius muscles are damaged, sometimes pain behind the ear and ear canal, decreased taste, decreased salivation on the afflicted side. In cases of injury within the canal, at the site I have placed the cross at, we will find hemifacial weakness involving the muscles of expression, that is all the muscles of expression. Normal tearing, since the preganglionic parasympathetic fibers have already left the main trunk of the facial nerve. Hyperacusia, pain behind ear and ear canal that is present sometimes. Decreased taste and decreased salivation in the affected side. So the answer to this question is A. Next question. A patient with acanthosis nigricans that develops a facial palsy is likely to have A. a pontine tumor, B. herpes zoster, C. diabetes, D. Lyme disease. I will mention 9 causes of peripheral facial palsy. I think 7 of them were mentioned in the first 8 USMLE Step 1. 1. Probably the most common cause of peripheral facial palsy is reactivation of herpes simplex. In this frame, you can see 3 photographs of the same patient. In the first photograph, you can see perioral swelling with crusting blisters around the lower lip. This is the typical lesion seen in labial herpes simplex infection. 2 days later, she developed an isolated paralysis of the right side of the face. And 3 months later, right hemifacial weakness was still present. In many cases of facial paralysis suspected of being produced by herpes simplex reactivation, cutaneous manifestations are not present, yet treatment with acyclovir is recommended. 2. Other condition associated with facial palsy is sarcoidosis. Notice that the weakness of the left half of the face is associated with inability to close the left eye, resulting in Bell's phenomenon. Bell's phenomenon is a physiologic event. Most normal people, upon closing their eye, the eyes go up and out. This is usually not seen because the eyes, when closed, are covered by the eyelids. In cases of unilateral paralysis of the facial nerve, since the eyelids do not close down, we can see the normal phenomenon of the eye going up and out. This is called the Bell's phenomenon. Patients with sarcoidosis often have erythema nodosum. 3. This photograph shows a patient with a left peripheral facial nerve palsy and limited left eye abduction, indicating a cranial 6 nerve palsy. In this case, this association was due to fracture in the temporal bone and basilar skull damaging the nerves. 4. In this new frame, you can see the MRI of another patient. This patient presented with a right peripheral facial nerve palsy and a right 6 nerve palsy, and a lesion in the right facial colliculus. You also see in this frame an anatomical specimen corresponding to the level of the lesion presented in the MRI. In it, you can see the nucleus of the 6th cranial nerve and its corresponding fibers. You can also see the motor nucleus of the 7th and its corresponding fibers going backwards, cranial nerve 7 internal genu, and the bulging into the 4th ventricle produced by the facial fibers going around the 6th cranial nerve nucleus. 5. This frame shows the famous Ramsay-Hunt syndrome. This syndrome is produced by herpes zoster, and it is characterized by vesicular lesions in and about the ear canal. Remember that at least in part the ear canal cutaneous sensation is innervated by the 7th, and ipsilateral facial weakness. 6. You can see the left half of the face not being able to smile, indicating a left peripheral nerve facial palsy, and the skin lesion characterized by Lyme disease. This patient had Lyme disease facial nerve palsy. 7th, This patient has a right peripheral facial palsy. Notice that it's not clearly seen when the patient is not crying. The palsy was due to a parotid tumor, big enough to be seen by just turning the ear. Eighth, this is a picture of acanthosis nigricans. This condition is associated with diabetes mellitus. I put it here to remind me to mention diabetes as a condition often associated with peripheral facial nerve lesions. 9. The last cause of facial nerve injury I will mention is Melkerson-Rosenthal syndrome. This syndrome is characterized by recurrent facial nerve palsy, here involving the right side of the face, and a very peculiar tongue abnormality, often called geographical tongue. In patients with this syndrome, the palsy not always occurs on the same side. So the answer to this question is C. Next question. Most patients with viral facial palsy or idiopathic Bell palsy gradually recover function, but aberrant re-innervation can produce undesirable manifestations. A true, B false. Most patients with peripheral facial palsy recover well with no residual deficit. In a few patients, aberrant re-innervation produces unusual findings. Probably the most peculiar is crocodile tear syndrome. This term is used to describe the condition found in patients that, having recovered from a unilateral facial palsy, go on to develop a condition characterized by unilateral tearing when they see food. I will explain how this happens in the next few frames. I hope you recall this figure. It depicts the non-striated muscle structures innervated by the facial nerve. I will now peel away some of these structures in this figure to better visualize the autonomic system. The first structure I will remove is the sensory component of the seventh nerve, represented in red. Now I will remove the taste fibers in solitary nucleus. So we're left with the autonomic component of the facial nerve. I will now proceed to label the most relevant structures for our subsequent explanation. Here I have labeled the greater superficial petrosal nerve, pterygopalatine ganglion, chorda tympani, and the submandibular ganglion. I will now, in order to distinguish the fibers going to one or the other ganglia, use different colors. Those normally going to the pterygopalatine ganglion in magenta, those going to the submandibular ganglion in green, and a combination of fibers going to these ganglia at their origin, as you can see portrayed in this frame. Now that we have an understanding of the innervation of the parasympathetic ganglia, I will proceed to describe the type of lesion that can produce crocodile syndrome and the mechanism that produces it. A lesion in this region, as indicated by the cross, produces damage to the preganglionic axons that, traveling to the ganglia, a phenomenon that I have represented by turning the preganglionic fibers gray. Yet, when they grow back, it is only those initially destined to innervate the submandibular ganglion that do so, as represented by the green color of the preganglionic fibers not only going to the submandibular ganglion, but also to the pterygopalatine ganglion. Hence, the pterygopalatine ganglion neurons will be re-innervated by fibers destined for the submandibular ganglion, and as such, the thought of or the view of food and desire for it will produce not only increased salivation, but increased tearing. This is called crocodile tear syndrome. Another consequence of aberrant reinnervation is the cannot smile without a wink syndrome. In this syndrome, fibers meant to innervate the orbicularis oris end up innervating the lower facial muscles and vice versa. This is the appearance of a patient with this condition at rest. the patient had a right facial nerve palsy due to Ramsay-Hunt syndrome. As the patient closes both eyes forcefully, you can see the unintended contraction of the right side of the mouth, indicating that the fibers meant for the right orbicularis oculi have ended up going to the right lower facial muscles of expression. When smiling, the right eye closes, indicating that fibers for the lower facial muscle of expression have ended up in the orbicularis oculi. The same phenomenon occurs when blowing up the cheeks, as you can see here. So the answer to this question is true. Please take a look at this picture and decide where is the lesion. A, right centrum semiovale. B, right internal capsule. C, right pons. D, right medulla. I hope you are versed in this diagram by now. Here I have added the tracing of a man. We will use this figure to indicate the area of the brain injured and the distribution of weakness produced by such lesions. In this question, we were presented with 4 choices. I will navigate each of them in the next few frames. In the first choice, the patient has a right centrum semiovale lesion. Such a lesion will involve the opposite side of the body and the lower quadrant of the face on the same side as the body deficit. If the patient is asked to smile, the mouth will deviate in the direction opposite to the side of the weakness. In the second choice, the patient has a lesion in the right internal capsule. The patient will have weakness of the opposite side of the body and the lower quadrant of the face on the same side as the body weakness. If the patient is asked to smile, the lips deviate towards the side of the brain lesion. In the third choice, the patient has a lesion in the right pons. The opposite side of the body will be affected, but the face will be affected on the same side of the lesion. And the whole half of the face will be affected. If the patient is asked to smile, the lip will deviate away from the lesion. In the fourth choice, the patient has a lesion in the right medulla prior to the decussation of the body fibers. The patient will have left side body weakness. If asked to stick the tongue out, the tongue will deviate to the side of the lesion. Remember, when the action of a bilateral represented muscle is to go forward, the structure deviates towards the weak side. On the other hand, when the action is to retract, the structure would deviate towards the strong side. So the answer to this question is C. Next question. Fasciculation is a sign of lower motor neuron disease. A true, B false. Brainstem and spinal signs of lower motor neurons are weakness, atrophy, fasciculations, decreased deep tendon reflexes, decreased tone, no Babinski, and flaccid paralysis. Spinal signs of upper motor neuron involvement are preserved reflex in a weak wasted muscle, increased DTRs, clonus, Hoffman reflex, Babinski sign, spastic tone, and loss of superficial abdominal reflexes. Brainstem findings of upper motor neuron involvement are increased jaw jerk and clonus, increased gag, exaggerated snout, and forced yawning. So the answer to this question is A. Next question. Pseudobulbar palsy is characterized by dysarthria, dysphagia, facial and tongue weakness, and dash. A. Vomiting. B. Headache. C. Emotional lability. D. All of the above. All non-ocular brainstem lower motor nuclei are supplied bilaterally by cortical motor area except the lower motor neuron of the lower facial motor nuclei, as depicted in this frame. Cerebrovolvar palsy is due to an upper motor lesion caused by bilateral disturbances of the fibers innervating these nuclei. Thus, a bilateral lesion in the corticobulbar tract anywhere from the cortex to the pons produces cerebrovolvar palsy. Hence, muscles innervated from the medulla are often affected, producing dysarthria, dysphagia, and drooling, dysphonia, and tongue weakness. Pontine innervated muscles are also affected, producing difficulty chewing, bilateral facial weakness. In addition, episodes of emotional lability characterized by involuntary, uncontrollable laughter or crying also occur in these patients. So the answer to this question is C. Next question. You have two smiles, A true, B false. This case was published in 1992. You can really see the difference between volitional and emotional smiles involving the lower quadrant of the face. Notice the cortical lesion in the right presental gyrus, her inability to move the left corner of the mouth on command, but her ability to move the corner of the mouth during an emotional smile. This is so because smiling seems to be controlled by two upper motor neuron systems. One is concerned with volitional smile and the other one with emotional smile. The volitional pathway upper motor neuron is in the presental gyri. Fibers from the left presental gyrus reach the upper and lower segments of the right facial motor nucleus and the upper segment of the left facial motor nucleus. The right presental gyrus does the same on the opposite side. This is the system that we have been describing so far in this talk. The emotional smile pathway, most believe, probably arises from the limbic system or from the hypothalamus. From these structures, fibers in this pathway convey signal to the caudate nucleus. From the caudate nucleus, signals travel to the putamen. From the putamen to the globus pallidus. From the globus pallidus to the reticular formation, which I have introduced as blue dots with white spots in this frame. This innervation that is from the globus pallidus to the reticular formation is bilateral. The reticular formation is in the midbrain. And from the midbrain, reticular formation probably by way of the red nucleus to the facial motor nuclei as indicated in this frame. Hence, a stroke in the area indicated by the red oval structure in this frame does not interfere with emotional smile. So the answer to this question is true. Next question. All authors agree that the volitional innervation of the upper half of the face arises from the presental gyrus. A true, B false. This is the classic explanation for the innervation of the facial motor nucleus for volitional expression. According to this classical explanation, the volitional innervation of the upper half of the face arises from the presental gyrus. In Neuroscience 6th edition, a different explanation for the innervation of the facial motor nucleus is given. The difference is that the upper half of the facial motor nucleus is innervated by fibers from the contralateral and ipsilateral cingulate motor area. Hence, a lesion affecting the presental upper motor facial fibers will affect the lower face but spare the forehead muscles, because the innervation to the forehead muscles arises from the upper half of the facial nucleus that is innervated by fibers from the cingulate gyrus, and these fibers are not involved in this lesion. Clinical manifestation would be the same with contralateral internal capsule lesion, because the ipsilateral upper motor neuron innervation from the cingulate gyrus will not be affected, and it will suffice for the contraction of the forehead. Whereas a lower motor neuron lesion, as in the classic explanation, will involve the upper and lower quadrant of the face as indicated here. First aid adheres to the classical explanation, and so do I. So the answer to this question is B. Thank you very much for your attention.